Thank you. Monica, that was beautiful. Thank you. Thank you for sharing. And hopefully I can show you a little bit about how we've done similar thing within our work with Mitragyna speciosa. Originally when I came to find Mitragyna speciosa, I actually think that this plant found me. And I was studying Salvia divinorum. And I was asked by the National Institute on Drug Abuse to come and talk about naturally occurring analgesics. And along my study through that, I came across this plant. And this plant just sort of kept coming back and coming back and coming back. And Salvia divinorum faded away from my interest and our research. And this really sort of percolated to the top and became something that was at first a effort to isolate alkaloids, determine we could find new analgesics from these alkaloids. And we were met with a lot of resistance because these compounds had nowhere near the affinities for opioid receptors that the traditional opiate-like molecules of morphine, oxycodone, and these types of molecules had. And so study sections at National Institutes of Health basically laughed us out of consideration. And so it was kind of interesting when I was in the shower one day. I was thinking, why is this plant so important? How is it utilized, and how is it existing with its native population? And it's used as a tea. And so I said, why are we trying to isolate out every single compound and understand every single compound when it's a unique symphony orchestra that's existing together, right? And so why take each instrument out? Well, we have to take each instrument out from that objective scientific standpoint to look at what those potential contributions are to the overall. And so we've gotten into this from the last time I was here into a much, much deeper level, working very closely with horticulturists now, plant biosynthetic chemists, and then, of course, pharmacologists to sort of go a little deeper and further into what we are understanding that this plant is really trying to teach us. I mean, Monica, that was just a beautiful way of describing this, because I'll share a couple of lessons along the way where we've learned from the plant instead of what we were looking for. So let me bring you up to speed. First of all, what is Kratom, or Mitragyna speciosa as it's known? Just to put everybody on the same playing field if you're not aware of this plant. It comes from the family Rubiaceae, which is the same family of the coffee plant. This plant and this genus doesn't seem to contain caffeine in it, so we don't see that similarity that we do with coffee plant. But Mitragyna speciosa and the Mitragyna genus was actually named from the shape of the leaf. If you take the leaf here and turn it negative 90 degrees and stand it sort of straight up, you'll see that resembles a bishop's hat or a mitres hat, and that's where the name Mitragyna came from. This is a plant that's found, or a tree that's found in tropical Southeast Asia, particularly at the interface of peninsular Malaysia and Thailand. This is the richest area of concentration of these trees. It's since spread probably by human propagation all across Southeast Asia, and most of the material that's coming into the United States and into the Western world is actually coming out of Indonesia now, not from Malaysia or Thailand. It's referred to as Kratom in Thailand. We hear a lot of it in the Western world called Kratom. Kratom is a word that was pretty much, or a pronunciation that was pretty much created in the Western world. That pronunciation is not recognized in Southeast Asia. So Kratom or Kratom or Kitom, which is called in Malaysia, or Biak Biak, are the known sort of pronunciations. And the way I look at it is it's tomatoes and tomatoes. We all say Kratom, 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 whatever it is. We all know what we're talking about in that context when we're speaking about this plant. I think one of the other interesting points, and this is something that we've really been thinking about lately, there's over 40 different alkaloids that have been reported to exist from this plant. no one's looked at anything else. Everyone has focused on alkaloids. Historically, that makes sense because plants that contain alkaloids are thought to be the bioactive compounds of these plants. But there are other perceptive qualities that don't seem to be coming from the alkaloids. And so this is something that is totally untouched right now. You need me to move this? All right, I try not to get too loud. So there's a whole plethora of other compounds within the plant that we haven't really even scratched the surface of yet. So we focused on alkaloids because that's sort of the low-hanging fruit, if you will. The top right-hand corner of this slide shows you the flower and the seed pod of this plant that occurs about once a season. It's a beautiful flower. And it contains a number of different alkaloids, or a concentration of different alkaloids than do the leaf materials. However, most of the individuals that we've talked with in Malaysia don't tend to use the flower as anything special. So they will just particularly harvest the leaves freshly and use those. And what does that look like? So the typical use of Kratom in Malaysia and Thailand is a tree growing down here in the left-hand corner, which we were lucky enough to be there when they were flowering. Those trees are really almost in everybody's yard in that region. And it's legal to have your own tree. It's legal to have your own production of and use of Kratom. It's not legal to sell it in Malaysia. However, you can see just to the right of that, a roadside stand where you can stop and pick up your beverage of choice. In this case, the traditional preparation is fresh leaves are plucked, about 5 kilograms are put into about 5 liters. Those leaves are cut with just regular scissors to expose more of the surface area. They're boiled for about 2 to 3 hours. In that time frame, and then the juice, as they call it, or tea or decoction, is packaged into baggies. And I thought this was the weirdest sort of way to carry your drink for the whole day, but it's apparently a common drink vessel in Malaysia. So when we were down in the regular parts of Kuala Lumpur, we would see kids walking around with bubble tea in plastic bags with a straw sticking out of it. So I said, okay, I guess it's not that unusual. They do put them into water bottles as well. But the tea will, obviously, as it cools, you can see that it becomes cloudy and there's a precipitate in there. Now, normal folks in Malaysia will say that after 48 hours, the tea has no more activity. The interesting part of that is all the alkaloids are still intact. So there's something that this plant is, again, trying to teach us that we're ignoring, and something that we're very, very interested in really trying to understand. So this is brewed, this is utilized about 3 times a day, morning, afternoon, evening, and they will split this with either room temperature water, ambient water, or warm water. And then they'll consume those. Very much like we would consume coffee or tea in our normal day of activity. And this is also something that's titrated to the effect. So some mornings I wake up and 1 cup of coffee is enough for me. Some mornings, like this morning, maybe 2 or 3 after the flight over. So, you know, it's something that's titrated to the effect. It's not a prescribed dosage, in other words. So this has been used historically by really outdoor laborers to be able to prolong their ability to work in the hot sun climate, also to relieve pain as they work, and it has a paradoxical pharmacological approach, which I actually have started to coin in talking about disruptive technologies and disruptive areas. I really think of Kratom as disruptive pharmacology. And it's really got this categorical emptiness. The FDA in the United States really wants to classify it as an opioid. It's not an opioid. it's fundamentally wrong, in my opinion, to classify it as an opioid. And it has been stuck in this box because we want to put things into a box. But it's completely not opioid. It has qualities of opioids. It interacts with opioid receptors. But again, it's the symphony orchestra of activity that's really, really fascinating. And it does have this stimulant activity. Many of these indigenous farmers and laborers also use opium, still traditional opium preparations to this day. And when they run out of opium, they simply increase their dose of Kratom so they don't go into withdrawal. And this really sparked our interest because we have a worldwide, particularly in the United States, opiate crisis. And could this be something that could help in finding a natural alternative treatment to something that nature has already provided us, that's been now moved into a crisis standpoint. So this really started to sort of crystallize our thought process around where we wanted to go with looking at this, moving away from really looking at analgesic activity, although we're still doing that, but really looking into, can this be something that would be useful in opioid use disorders and helpful to the world from that standpoint. We actually have done a lot of work and collaborative work with scientists at the University of Science Malaysia in Penang, Malaysia. And one of the most recent surveys that we did with them found that polydrug users, or people that are using opiates along with methamphetamine, are actually finding that Kratom is being able to reduce their usage of methamphetamine. And so this is interesting from many standpoints. There was a study, I was at the University of Mississippi before being at the University of Florida, and kudzu is a predominant plant in the southeast. And kudzu was being studied for its effect to reduce alcohol intake. And what we found was that kudzu actually increased the bioavailability of alcohol. And so you needed less alcohol to get the same effect. And so there's still questions about what's happening here. Why are we reducing methamphetamine intake, or supposedly reducing methamphetamine intake? Is there some pharmacokinetic consequence that's causing this? Or is it actually working in neurotransmitters to sort of, block out that effect? This is something we're very interested in. The National Institute on Drug Abuse is extremely interested in the United States because we still have no FDA-approved treatments for methamphetamine or cocaine. So this is something we're sort of diving into, just to give you a teaser. The predominant, or at least thought to be predominant active agent, is Mitragyna, or Mitragyna, again, tomatoes. But Mitragyna, as I like to call it, is a coinanthine-based alkaloid, indole alkaloid, and is an interesting molecule from many standpoints. And we finally feel like we have an understanding of how it's interacting now with different G-protein coupled receptors in a different fashion than what we thought of originally when we compared it to structures of opioids. And again, we'll come back to, that was where everyone was pointing the sort of light, was opioid, and we're learning that it has so much more. So that's Kratom use in the traditional sense. Kratom use in the United States and the Western world looks very, very different. These are the products that you would see available in the internet or in vape shops or different smoke shops. In fact, right off of our campus, I can walk to a smoke shop and there's a whole wall of Kratom products available, which we've purchased every one, analyzed every one, and interestingly enough, they're quite different, which isn't too surprising from a natural product. Thankfully, I would say more than 90% of the products we analyze actually contain what they say, which is a step in the right direction for herbal products in general. But you can see here you have energy shots, you have just leaf material that's either been crushed or you have finely ground powdered leaf material. There are tablets and capsules, some of which are marketed under what you would think of as a herbal product, where you see premium Bali, Mitragyna speciosa, or Mengda Mitragyna speciosa, which is supposed to be the highest quality. And then you have other products that are called Foria, which definitely have a different connotation to what you might expect when you take a product like this. And then you also have products like Viva Zen. Viva Zen is one of the energy shots. It's combined with many other herbal products. It was actually first sold as Vicodin. And if anybody knows the prescription trade name in the United States for hydrocodone, it was Vicodin. So the FDA actually came in and made them change their labeling, so they changed to Viva Zen. Just some stories of how this has moved from a traditionally used product, a legitimate use by many people across the world to really get off of opiates or to improve their energy, versus the very small population that's using this to get high, and has turned it into a very controversial product. This is old data now, 3 years old, about 2,000 metric tons coming into the United States every year, according to the American Kratom Association. And if you look at a typical dose of about 3 to 5 grams, that suggests in the United States alone there's around 15 million users. This puts it into a pretty high level of use category within the U.S., and I think that number's probably greater now. Definitely during COVID, the sales, according to a lot of the vendors of Kratom products, has gone substantially higher than it was pre-COVID, and these numbers are pre-COVID numbers. So it brings to the question, is Kratom a threat or is it a therapeutic? And how do we do this? So as I mentioned, anecdotally, it's been used for chronic pain, mood elevation, opioid use disorders. We ourselves have reported adulterated and contaminated products into the scientific literature. Why individuals would take a very inexpensive natural product and put highly purified, expensive pharmaceuticals into it, and then sell it at a very inexpensive price, only to me feels nefarious. And what they're trying to do in that marketplace is capture a group of people to get return customers, not really contribute to making the world a better place. And it's really sad. But I will take it a step further and say that we've seen adulterated products with substances that we can't identify as well. So we've fingerprinted these. We know what alkaloids should be present. And then we can see abnormal spikes in mass spec analysis. And we can get what the mass is, but then we have to go and try and figure out what these compounds are. And when you're having a small amount to analyze, you can't get it. It's like looking for the sort of proverbial needle in a haystack. You have to know what you're looking for in order to identify what it is. A lot of our thoughts and a lot of the mass range that are in there probably fall into the synthetic cannabinoids and synthetic fentanyl type derivatives that are around. And so when we see individuals that have consumed too much of this material and that have ultimately passed on, there's very few reports that have kratom as the sole source of death. And those few reports we still have to question because they may have been contaminated with other items that we just don't know. Because in Southeast Asia, there's not been one report of death linked to kratom for centuries of use. And so this is a very interesting paradox in the world. There's claims that kratom is severely addictive and deadly. I touched on the deadly part. I think I've been now working with a lot of addiction physicians over the years, and interestingly enough, some of them are starting to use kratom in their practice to move serious opiate addicts off of those opiates and onto kratom. Then the question is, where do we go from there? So we're working on that piece. But they're also starting to treat individuals that have been extreme high users of kratom heavy users that are not able to get off of Kratom. And so the big question is, how do we do this? Do we give them buprenorphine like we would a normal opiate addict? And we have discussions over lunch that maybe this isn't the right approach, because if this truly is not an opiate, why would you put somebody on an opiate and now make them opiate dependent on a buprenorphine product? So there's a lot of debate and questions, but if you look in sort of the medical literature right now, that's sort of the standard of care. Just go ahead and treat them with buprenorphine. So we're trying to figure out what the best outcome would be in terms of treatment. The U.S. Food and Drug Administration has driven a lot of action towards regulation around Kratom. In fact, when I spoke at the 2017 conference, we had just come off a historical decision by the DEA that was trying to place Kratom in Schedule 1, and for the first time ever backed off of an intention to do so. It's still in that gray area that it could be scheduled at any point in time. To the best of our knowledge, we don't feel that it's headed in that direction anytime soon. The U.S. FDA put pressure onto the WHO to put an international ban on Kratom, and I was fortunate to be one of the few people invited to speak to the WHO expert committee on drug dependence, and this was actually, as you can see down here, United Nations panel actually rejected the international Kratom ban because of a couple of reasons. One, it's an indigenous medicine that many people are using, or indigenous product that many people are using in Southeast Asia on a daily basis. And two, the emerging science really shows that there's some promise here in terms of helping a greater population than it can hurt. And so we'll see where this goes. And unfortunately, today, Kratom is still illegal in 6 states. In the U.S., Alabama, Arkansas, Indiana, Rhode Island, Vermont, and Wisconsin. And it's illegal in certain counties and cities throughout other states. But it's confusing. On the other side, the United States government and several state legislatures have been working on passing what's called the Kratom Consumer Protection Act. And that has passed in several states, where there will be some regulatory backing behind products that are sold in those states to ensure that they're meeting label requirements and unadulterated and past GMP production. So there are some things going in the right direction, but there's still this sort of overall question: is it a threat or is it a therapeutic? One story from USA Today, the headline read, U.S. herbal drug Kratom linked to almost 100 overdose deaths from the CDC. If you read that article in the entirety, the very end of that article says all the samples were laced with fentanyl. Yeah. So, what do you want? But let's come back and get a little sciencey here. As I mentioned, the few deaths have been attributable to Kratom alone, and really we're questioning if any are. We do know that Mitragyna is a partial mu-opioid agonist, and so it does have mu-opioid activity, but that's not all the activity that occurs. And it has this 40% maximal activation effect, so it's a partial agonist, which is very similar to what buprenorphine is. Buprenorphine is a mu partial agonist, very effective at getting people off of full agonists, but then where do you go from there, right? So, sorry, we're slow. Whoops. There we go. So this is just to show you against the standard that would produce 100% agonism in the right. As we increase concentrations of Mitragyna, you only achieve 40% maximal effect. The thing that came out that made Mitragyna a little bit sexy at the time was that it was a biased agonist, or what we think of an agonist that only recruits and activates the G protein of a G protein coupled receptor, and does not recruit another protein called beta-arrestin. Beta-arrestin, as its name suggests, would arrest the signaling and arrest the function of the receptor, and it's thought to be tied to many of the side effects associated with opioids. So respiratory depression, constipation, potentially tolerance, but nothing around the abuse or addictive possibilities. But these molecules were exciting because with low respiratory depressive and low constipative effects, they could offer a better alternative to the clinically used opiates that are there today. And this was work that was done by our colleagues, Dalbor Sims and Andrew Krugel, and was published in JACS a number of years ago. And we decided to really dive into this and think from a therapeutic potential of kratom, where could we go? The first and foremost for us was opioid detox. And what I'll show you is some pharmacology that suggests that kratom alone would be a single concoction that someone could ingest instead of having to take several prescription medications to treat detox, which would really improve adherence and also potentially improve the chances of them completing detoxification. So there's opioid activity here, there's adrenergic activity, there's serotonergic activity, there's analgesic and anxiolytic activity, and I'll show you those in a little more detail. The other area is medication-assisted therapy, which is really what we're doing in the space of methadone and buprenorphine these days, but using kratom to reduce opioid use. We know that this has been something that's been going on traditionally, but we also see it very anecdotally through surveys in the United States and actually around the world. Many people are using it to really move themselves off of prescription opiates. And one of the biggest reasons is because they, one, don't go into withdrawal, but two, this has a mood-enhancing property that will help them re-engage back into society. So I get emails all the time from people that say, before I found kratom, I was laid out on the couch, my family sort of disowned me, I wasn't paying attention to my children or my pets or my plants or anything. I found kratom and I'm back up, preparing meals for my family, doing whatever it is that I used to do, and my pain is under control, and I'm not taking hardcore prescription opiates. And so there's a lot of promise from the anecdotal side, and really the withdrawal is quite mild on the subjective opioid withdrawal scale. I won't go into details of that just for time, but the overall withdrawal seems to be mild. Now, you will have cases and exceptions to that where individuals will say they can't stop at any they have to take it at a regimen at a very high dose. But in the normal sort of low dose usage, maybe 2 or 3 times a day, there's very little withdrawal. So the problem is that we've had a lack of standardized product to really look at this and do rigorous clinical trials to evaluate any claims associated with the pharmacology. So in comes my favorite horticulturist in the world now, Brian Pearson, who's an assistant professor at the University of Florida. And we now have our own sort of kratom farm at the University of Florida. We have approximately 100 trees in ground. We have 300 or so trees in greenhouse. And what it's allowed us to do is start to really study what are the plant's requirements for nutrients, what are the plant's requirements for sunlight, basically all the environmental production. And why is this of interest in Florida? Well, the University of Florida actually has been behind us very strongly. And this is the first example of a cross collaborative research project between the UF Health Center and the agricultural school. And we have a huge project going on now where we're working through understanding how we can improve actually the economy of the state of Florida. So if you're not familiar, Florida is very famous for citrus. The citrus plantations are in great danger right now because of greening, which is really destroying the citrus. And what Brian has been able to do is figure out that we can replace every citrus tree with a Mitragyna speciosa tree, utilizing the same spacing, utilizing the same irrigation equipment, utilizing all the same farming equipment, that's utilized in that industry. And so it's just a matter of now educating the farmers on how to grow these trees properly. So if they are able to take off, we believe that we'll be able to help the economy of Florida by transferring citrus industry into hopefully some sort of beneficial herbal and botanical drug product industry. But along the way, we've also determined that there's at least 2, potentially 3 different chemotypes of Mitragyna speciosa. And this immediately made me think of cannabis. And so we have very high producing Mitragyna trees, and we have trees that produce almost no Mitragyna. And the interesting part of that story is all these trees were donated to us by individuals from around the state that have been using them as their personal fresh material and not going and buying dried material. And every single one of them said that they gave them the exact same experience as to the dried materials that they had bought. Dried materials are really sold in the marketplace based on their Mitragyna percentage. And so, again, we're starting to think that the big spotlight has been on Mitragyna for all these years because it's the most abundant alkaloid in some trees. And that's where everyone's been looking at it. And in the products that are available in the United States, it is absolutely the most abundant because that's how those products are selected for sale in the U.S. So it's easier to extract and purify and study that. And almost all the studies that are in the literature are with Mitragyna. They're not with Kratom itself. And so it's a big difference when you start to really look at those. But we just harvested our first large harvest of fresh leaf from low Mitragyna producing trees. We made tea in the traditional way, fresh. We just finished freeze drying all of that. I call it astronaut kratom. But it's all ready to finally go into animal studies. And we'll do head-to-head animal studies to see if those materials that are lacking Mitragyna are actually going to be as beneficial as those that seem to have Mitragyna. And so coming to those alkaloids, Mitragyna has always been touted as the major one. It's supposed to be 66% of the total alkaloid content. That number came from a sampling of 3 trees. And it has stayed in the literature from the time that it was originally published. What we are seeing in actual samples that we harvest and samples that we're purchasing in the marketplace now is Mitragyna accounts for 0.7% to 38.7% of total alkaloid content. So much less than what was initially thought of and initially reported. And then 7-hydroxymitragyna, which is on the far right of this slide at the top, is also one of the more studied metabolites of Mitragyna. And it was thought to be produced in the plant. We now know that it is most likely a post-harvest artifact. We cannot find any biological enzyme within the plant material that will convert Mitragyna into 7-hydroxymitragyna. And it was thought to be originally about 2% of the total alkaloid content. What we find in almost every sample, and thankfully in many of the products that we're testing in the marketplace, that the 7-hydroxy is less than 0.01% total alkaloid content. This will become important when we start talking about the pharmacology associated with these. What the other really cool thing is if you notice, like I can show this to my little kids and say, hey, what about these looks the same? Right? It's the old Sesame Street type paradigm. And if you look, every one of these molecules has this similar appendage at the bottom of the molecule, or the southern part of the molecule. This is a beta-methoxyacrylate structure. And why the plant would decorate every single one of these unique alkaloids with that same chemical feature really became something of interest to me. And why, again, what's the plant trying to tell us? What is going on here? These are also moieties that are found in a class of natural products called strobilins, which are naturally occurring antifungals. And so we started to wonder, do these have antifungal properties? Because Mitragyna speciosa grows in swampy environments. In fact, it can grow in standing water, perfectly happy in standing water. And so in that environment, you must think that the pressure from fungus is got to be tremendous. And so, interestingly enough, we have found that the genes for all alkaloid production are within the root system. We don't find any alkaloids in the roots, which is interesting. So I think they're being synthesized there and quickly distributed, whether it's into the environment around them, which we haven't explored yet, but they are quickly sent through the tree into the leaves. There's very little in the bark, there's very little in the stem, but there's high concentration in the leaf material, and we believe probably in the surrounding area. So we're investigating the antifungal properties. Interestingly enough, it has no activity on human antifungal pathogens or human fungal pathogens, but we have seen a pretty nice broad spectrum of activity against plant pathogenic fungus. So this is another interesting area that we're pushing, and again, to be collaborating with the agricultural school and be able to explore different pathways has been really fascinating. These are just some of the ones that we've isolated and we've studied and taken out of that symphony orchestra and listened to every single one of these guys on full blast. And when you do that, it's a totally different story than looking at the full plant, right? And I have to always remind even myself what we're doing there. We were one of the first groups to profile Mitragyna against 82 different central nervous system drug targets. I showed this data before. We redid this screen recently, and because the screen has been updated with all human receptors and it's been expanded. This is a 10 micromolar concentration. These are the hits at 10 micromolar. 10 micromolar obviously is basically bathing these targets in this molecule, and what we found is that we have some serotonergic activity, some alpha adrenergic, dopaminergic, and then there's your opioid, the kappa and mu opioid receptor within that whole soup, right? But when we drop down to 100 nanomolar, you don't see any hits. And so this is, again, where I start to get into this sort of, okay, yeah, it got opiate activity, but at 10 micromolar, it's hitting all of these different systems. How physiologically relevant is that? We started to then mine into each of these targets individually. One of the things that we were most interested in was the alpha adrenergic activity, because when opioid use disorder patients are treated, they're given methadone, buprenorphine, and as they're going into withdrawal, they're oftentimes given clonidine, or now the FDA-approved lofexidine, which are alpha-2 adrenergic agonists. And what we found interestingly in many of the kratom alkaloids is that they have this partial mu opioid activity plus this alpha adrenergic activity as well, which would make them suitable as single agent treatments for opioid withdrawal syndrome. So we've been looking at those as well, aside from the plant, but the whole plant material in those same paradigms. And again, we found that, of course, this is a mu partial agonist. It interacts with kappa opioid receptors, but it does interact with alpha adrenergic receptors to degrees that are physiologically relevant. We can actually see these activities in animals, particularly animals that have been genetically modified to not contain opioid receptors. And so I'll go into this in a little more detail, if I can. Poison control centers across the United States actually provided us another key indicator here that kratom overdoses resemble stimulant overdoses, not opioid overdoses. So you get agitated delirium, you get seizures or convulsions, but you do not see very often respiratory depression. So this was another indicator that started to bubble up and tell us there's other things going on within this plant. And so we wanted to look at just a hot plate assessment of Mitragyna, and you can think of this as when you're barefoot out on the pavement in the summertime, the first couple steps are okay, and then all of a sudden you want to get to the grass as quickly as possible because your feet are burning. So we do that with these animals. We put them on for a limited period of time, and as we increase doses, you can get to a point where you achieve 100% anti-nociception. So they'll stay on that apparatus the full amount of time where we take them off of the apparatus because we don't want to damage their tissues, we don't want to harm the animal in any way. But we can get to 100% analgesia, and that's in the wild type mouse. Here is in the sort of brownish colored circles. Then we took the genetically modified opioid receptor knockout mouse, and we took that same dose of 100 milligram per kilogram, and you can see there's absolutely no analgesic activity, which really, if you stop the experiment there, you say, okay, it's mu opioid receptor mediated analgesia, period. We've pushed the dose in those knockout mice a little higher and then a little higher, and what you could see at 200 milligram per kilogram was actually about 40% analgesic response. And we said, some of those other receptor mechanisms are kicking in at the higher doses. And so we wanted to really push that and see what was happening. And we took yohimbine, another sort of related alkaloid that's an alpha adrenergic antagonist. We pre-treated those animals with yohimbine, those mu opioid receptor knockout animals. And what we were able to do is pretty much completely block that analgesic efficacy that we saw in those animals. So there's a adrenergic component of analgesia to Mitragyna, and by extension then to Kratom as a whole. So this was exciting. I'm not going to spend any time on this slide other than to tell you that if you still want to see the most complete study that's ever been done on Mitragyna in the literature, it's in this paper by Macco in 1972. Smith, Klein, and French actually took this into full clinical development as a compound 12-711, and they stopped it. They stopped it because non-steroidal anti-inflammatory drugs were coming out, and they didn't see any advantage over this molecule to codeine, and this still had to be isolated and purified from the natural product. So they decided cost versus efficacy wasn't enough. I think one of the most striking pieces of data that we've collected so far is a neuropathic pain model and looking at Mitragyna, and this is not published, so this is the first time that this is actually being shown. We took rats and we created what's called a chronic constriction injury. So we cut open their thigh, we take their sciatic nerve, we ligate the sciatic nerve, and then we let those animals heal for about 3 or 4 weeks, and then we test them with pressure. We subject them to grams of pressure through an apparatus called Von Frey, which is a filament that goes up through the cage and pokes them in the paw. And the nice part about this assay is you can actually use the same animal as its own control because one leg has not been damaged, the other leg is damaged. And so we can look at the contralateral, ipsilateral in the same animal. So this data, just to show you on the left is morphine. And morphine in this model will take these animals from not being able to, at a very low dose of morphine, they can't withstand any pressure on that paw. But as you increase the dose of morphine, they can certainly withstand the full amount of pressure. Okay, that can be completely blocked, as you see in the black triangles with naltrexone, the opioid antagonist. We move over to Mitragyna, and we see that Mitragyna has a dose-dependent increase in anti-allodynia, same that morphine does, right? So this we thought was really promising. And then the question was, well, is it opioid related? So let's put naltrexone in. And what you can see on the far right graphs is naltrexone is not able to reverse this type of pain. Not fully, at least. And so this is really encouraging because this means that the treatment of chronic pain, and many individuals that are using Kratom are saying it's great for their chronic neuropathic pain. It appears not to be opioid-related mechanisms. And so we're really digging into this now to understand this in more detail, but it definitely is not as dramatic a reversal as you see with morphine. So what about 7-hydroxymitragyna? That was the other big sort of controversial compound in the plant, which we found out is not really in the plant. It's a metabolite probably made through oxidation. Now that we have enough trees growing of the the true chemotype, or what we think of as the high mitragynine chemotype. We actually are starting to conduct post-harvest studies on our own to see what changes the production or affects the production of 7-hydroxy, that we could see great spikes in products in the marketplace. This molecule is probably the most selective opioid I've ever seen. I've been working in opioid chemistry since 1998. And most of the opiates will start to pick up glutamate receptor activity at high concentrations. This molecule at 10 micromolar concentration doesn't pick up anything except for mu, delta, and kappa opioid receptors. And when you drop it down to the 100 nanomolar, it only kicked off mu opioid receptor. And so we did a full profiling of this, and we see that it's a very high affinity mu opioid receptor agonist. And then it brought up the question as to several things. One, is this the abuse component of the mixture? Is this an addictive component of the mixture? Should we try to figure out how to D7-hydroxylate this like decaffeinated coffee? Is this the problem? And so the first study that we did was actually with a colleague, Scott Hemby at High Point University, was to look at self-administration. And self-administration in addiction science is sort of the holy grail, the gold standard. If you show that a compound is self-administered, then it probably has abuse potential. So Scott was able to train mice to self-administer morphine, and what you generally see in this case is they're pressing a lever so many times and they'll get an injection of drug. And then there's a timeout period, they'll get another access to drug at a higher dose. And so they will continue to self-administer and feel good until they get to a dose that's so high that they don't need to administer it as often. We call that sort of the drunk phase or the high phase, where you'll start to see this curve go in the opposite direction. So you get this inverted U-shaped pharmacological curve. So once you have an animal that's trained on how to self-administer morphine, you can swap out that bottle of morphine for any other drug and see if they will self-administer that compound, or does it behave like saline. And so we did this with mitragyna, and what you can see is, along with saline, it never, across many doses, it never really was self-administered in those animals. So mitragyna in itself, we don't think has abuse potential or abuse liability. 7-hydroxymitragyna, on the other hand, you can see that typical inverted U-shaped curve, and it has readily substituting for morphine in the self-administration assay. One thing that we also did, longtime collaborator of mine, Jonathan Katz at the National Institute on Drug Abuse, he called me up and asked me for mitragyna, and I said we were already doing the studies with Scott Hemby, and so I said I can't give you any mitragyna, but here's a place to buy it. So he bought it, and he did a more elegant study than we did. But what he did was show that you can, by pre-treatment with mitragyna, you can actually dose-dependently decrease and completely block heroin self-administration. And that's what this graph on the left shows. That mitragyna alone at a 3 milligram per kilogram dose was able to unsurmountably block heroin self-administration. So another nice piece of evidence that shows that this molecule, again, not the whole plant material, may have potential in this area. And I won't go on to the other slide there on the right. And there was some evidence back in that paper by Mako from SmithKline in French that when mitragyna was given orally, it was more potent than when it was given by any other route. And we found this to be interesting. So we did a quick comparison in a warm water withdrawal test. You can see morphine in blue in different doses and antinociception percentage up the side there. 7-hydroxy, much more potent than morphine, not surprising to us. And mitragyna, much less potent than morphine, again, not surprising to us. These were given subcutaneously. Interestingly enough, though, when you give mitragyna orally, and the yellow triangles there, you can see it almost is equipotent to morphine. And so there is a definite difference between oral delivery, which is the way that everybody's ingesting Kratom, versus an injectable. But I wanted to bring this back also to Kratom itself. So orally administered Kratom, you see it takes much higher doses of the whole plant material to get to the efficacy, but you can still get good analgesic efficacy by ingesting the full plant material orally. So what this made us think was, obviously there's some sort of intestinal metabolism that's taking place, and we went through and looked at rat liver microsomes and rat intestinal microsomes, and what we did was incubated those with Mitragyna, the compound itself. We watched for disappearance of Mitragyna, which is the red lines, and we watched for formation of 7-hydroxymitragyna, which is the black lines. And so you can see as Mitragyna decreases, 7-hydroxy increases, and so this is some sort of metabolite within the human system, as well as in this case within the rat system. So we wanted to know, is that pharmacologically relevant? Does 7-hydroxymitragyna contribute to the overall effects when it's being metabolized from the parent compound? So we took Mitragyna and we dosed mice, and we did this hot plate examination on them as well. And we did a very sophisticated pharmacokinetics, pharmacodynamics study where we looked at the amount of compound that was getting into the brain versus the amount of compound that was present in the plasma. And then those amounts we also looked at in that hot plate assay. And so we were able to figure out what brain concentration was relevant to the pharmacological activity. And what we found was the maximum 7-hydroxy that could be produced in those studies fell far below any of the actual pharmacodynamic effect in that product. And so the green line that you can see on that curve is actually the maximum 7-hydroxy concentration. And the red line that you see going up is the actual observed analgesic activities and concentrations in the brain versus that maximal possible effect. So you can never achieve the analgesia with just saying that it's the metabolite. So that's a sort of popular myth that's grown in the literature. We've been fighting this, but hopefully this study will really help to underline that there is no relevance of 7-hydroxy generated from Mitragyna. We also found that there was a unique metabolite in human plasma. We were doing plasma stability studies with 7-hydroxymitragyna, and 7-hydroxymitragyna was converted into another compound within human plasma as we were doing these studies. Interestingly enough, it had the exact same mass transitions, and so the molecular weight was identical to 7-hydroxy, but it wasn't 7-hydroxy. And to the chagrin of my postdoc, I made him scale up the plasma study to pull out the unknown compound, and then we went through NMR and mass spec to determine it was actually Mitragyna pseudoindoxyl. Mitragyna pseudoindoxyl was reported in the literature decades ago as a fungal metabolite of fungal fed Mitragyna species. Mitragyna was fed to fungus, and the fungus spit out this Mitragyna pseudoindoxyl, which is even more potent opioid agonist than 7-hydroxymitragyna. But we did a lot of studies on this and found out it has very poor brain penetration. And since it's a minor metabolite from the 7-hydroxy metabolite, we really think that there's no functional consequence of this metabolite in humans. It does exist in other species as well, so we were able to find this in all preclinical species that we've been studying: mouse, rat, dog, monkey, but it seems to be more common in human. We then wanted to interrogate which cytochrome P450 enzymes were involved, because this is important when you start looking at herb and drug interactions. And fortunately or unfortunately, however way you want to look at it, two of the most important CNS drug metabolizing cytochrome P450s are involved here. So CYP3A4, which is one of the major drug metabolizing cytochrome P450s, is the major pathway for the metabolism of mitragyna. And then CYP2D6, which is one of the major cytochrome P450s to metabolize things like antidepressants and antipsychotics, is also a minor pathway here. I won't go into many details there, but what we really wanted to know is is this a problem when people are taking Kratom? Because what we did was go through the FDA's FEARS database and look at how much drug interactions have been reported in the adverse events database to the FDA. And most of the drugs that have caused adverse events with Kratom are CNS active drugs, antipsychotics, antidepressants, and anti-anxiety agents. And so we really wanted to understand, is there some pharmacokinetic issue that's happening with co-ingestion of those substances? We looked at many of the alkaloids that we isolated. We looked for inhibition of cytochrome P450s. Mitragyna and corinanthidine, two of the compounds that are relevant when ingesting the whole plant, do have moderate inhibition of CYP2D6, which is the one that is responsible for all those CNS drugs as well, prescription drugs. And so there could be some caution needed to be thought of if co-ingesting antidepressants, antipsychotics along with Kratom, which sadly is many of the population that is using these, because they're using Kratom for the mood elevation, mood enhancement property. So it's something that just needs to be aware of. So the take-home message about Mitragyna is really this is atypical opioid with additional non-opioid pharmacology, what I call disruptive pharmacology. It shares some but not all effects with mu-opioid agonists. It has a low potency, a low efficacy. I didn't show you it has less tolerance than morphine and less dependence. We looked at a little bit of that. It does have very different discriminative stimulus effects, and so we can teach rats to be connoisseurs of morphine, and then we can switch out and have them try any other substance and say, is it like morphine? When you do that with Mitragyna, they don't think it's like morphine at all. 7-hydroxy, they think it's very similar. There is less tolerance, abuse, defense liability. Again, this isn't Mitragyna, this is Mitragyna, not the whole Kratom. Does have desired characteristics for a candidate for opioid addiction and withdrawal. And so the National Institute on Drug Abuse is actually moving forward and producing 5 kilograms of GMP grade Mitragyna now based on our work, and we're working in collaboration with them and the National Center for Advancing Translational Sciences, and hopefully that material will be made available into the NIDA drug supply program for researchers to start using Mitragyna in the clinic in the first quarter of next year. So we're excited about that. 7-hydroxy Mitragyna should be considered a constituent with high abuse potential. It may increase the intake of other opiates. I didn't show that, but in the paper with Scott Hemby, we did show that 7-hydroxy by itself will start to sort of kindle use of other opiates. Very selective opiate ligand, and we don't think that the extent that it's converted from Mitragyna in vivo is significant. So what about Kratom itself? And this is the lyophilized Kratom tea, what I call the astronaut Kratom. We basically look at it in comparison to morphine, either orally or intraperitoneally. Of giving lyophilized Kratom tea, we can see a ceiling effect. And so we get to 1 gram, 2 grams, 4 grams per kilogram of this lyophilized Kratom tea, and we don't get any higher than 40% analgesic efficacy. And so that's first and foremost one thing that's interesting. It doesn't seem that you could push the opiate system over the top. There's other mechanisms and other pharmacologies within this plant that are balancing and counterbalancing effects that are going on. We do know that at those high doses, it will last as long in terms of its length of action. It lasts as long as a typical 5 milligram per kilogram dose of morphine. So interestingly enough, it can be probably a really legitimate analgesic substitute. We do know that the analgesia appears to be purely mediated through opioid receptors when you look at Kratom as a whole. And so this backs up some of the things that the FDA is saying, but I still think that it needs to be put in the proper context and corrected. I won't go into details here, but we've shown through genetic knockout animals that this is a combination of mu and kappa opioid receptor. Conditioned place preference is a drug-seeking paradigm, so where animals will seek out a drug. And what we can see with lyophilized kratom tea is they won't seek it out. They're not interested in really trying to find it as they would be with morphine. We also looked into some of the liabilities, particularly sedation. We don't see kratom tea causing sedation, which makes sense because one of the things that is always reported is a stimulant. The other thing that we looked into was respiratory depression. Respiratory depression, obviously with opiates, is a severe issue, and you can see in red there morphine causing respiratory depression. You do see a little bit of a slight drop in respiratory depression in the first 5 minutes with kratom tea, but overall that rebounds quickly, and there's really no issue in terms of breathing. We also looked at precipitated naloxone withdrawal, and there's several animal groups here that are on different treatment mixtures of morphine and kratom or kratom alone, and those are all the ones that are almost abolished. And then you see just morphine by itself, and this is looking at jumping frequency, which is not something that a mouse does normally, but when they're in withdrawal, they do what's called popcorn jumping, and they just go all over the place. And we can attenuate this with kratom pretty nicely. Another effect that can be attenuated with kratom very nicely is teeth chattering, which is another withdrawal symptom that you can see. So what's going on when we give the whole product? What's happening pharmacokinetically? We do see mitragyna as being the largest exposure into the animal. We then see speciosa, which I haven't even talked about, as the second highest exposure. 7-hydroxymitragynine, which is not present in our alkaloidal concoction we give them, but you see it as a result of metabolism. And then corinanthidine, which is another product there. There's two other molecules, speciogynin and peinanthine, that are actual isomers of mitragynin, and those show up in the first hour and are quickly eliminated from the plasma. They are converted into metabolites that are active and long-acting active. I don't have all the data here and then don't have all the time to do this, but speciosa is an isomer of mitragynin. The only difference is the 3 hydrogen. This hydrogen is in the beta configuration instead of the alpha configuration. That changes the entire 3D structure of the molecule from something that's sort of flat to something that's bent. And this molecule all of a sudden gains higher potency and affinity at opioid receptors. This does have partial mu opioid agonist effects as well, and it may be the thing that's been overlooked in the plant, because this is much more active than mitragynin. It's almost as abundant as mitragynin. And so we just communicated a paper on this that's under review right now. So stay tuned for more details there. We did push corinanthidine, which is another compound, through the urine screen. We got many targets, but again, at 100 nanomolar, we see one that popped out. And this time it was the alpha adrenergic target. We took this into a deeper dive and found out that it has about 40 nanomolar affinity for the alpha-1D receptor and about 75 nanomolar affinity for opioid receptors. The only difference between corinanthidine and mitragynin is the lack of methoxy group off of this aromatic ring. So interesting that just removal of that, all of a sudden you gain high affinity at alpha adrenergic targets. Again, very, very cool from a medicinal chemistry standpoint of view. I mentioned peinanthine and speciogynin. These are two other compounds that we found that are in high concentration in the plant that also have high interaction with 5-HT1A and 5-HT2B receptors. So you're talking about 31 and 20 nanomolars at these targets. Again, these are some of the highest affinity compounds in the plant at any target. And everybody's focused on opioids. Now we have serotonergic activity. 5-HT1A is interesting because it's been reported to have it's been reported to reduce opioid-induced respiratory depression. And so that's interesting that it's within the plant's whole symphony orchestra that we have something to counteract respiratory depression. 5-HT2B is an anti-drug target. It's known to be involved in cardiovalvulopathy. These compounds are antagonists at that target, so we don't have an issue with concern there. And again, it's a weak agonist at morphine. This is speciogynin, almost exact same profile. The only difference between speciogynin and penanthine is the reduction of this exocyclic double bond here. And this is an isomer of mitragynin as well. So the difference here is this exocyclic ethyl group is in an alpha configuration instead of a beta configuration. And that small change completely flip-flops the pharmacology to high affinity serotonin. Interesting stuff. We proved that serotonin is real. It actually has analgesic effects as well, and you can block that with selective serotonin antagonists. And I won't go into any much detail other than to say clinical pharmacokinetics was published in a Thai study where they showed the maximal effects of maximal concentrations of mitragyna was about 120 nanograms per milliliter. Two individuals that passed in the United States from a Kratom overdose didn't have 120 nanograms. They had 1,800 and 3,500 nanograms per mil in their blood supply. So, anything in excess is a little too much. So we're talking 17 to 189 times higher plasma concentrations. And then I just want to finish with the first clinical pharmacokinetics study was published in the United States on March 11th of this year, not from our group, but from Mary Payne's group at Washington State University. This was a single 2-gram dose given as a tea. They had 8 patients. 2 grams, by the way, is a very low dose. They had 8 patients that they signed up to. Those patients had nausea and vomiting when they started, and they were excluded from the trial, so 6 were included. But this provides a really good foundation for more clinical research to take place. There are some planned human trials. There's an FDA contract that's been awarded to Alta Sciences, and planning is underway. Those patients are supposed to be dosed in September of this year. And then Nutrisource, a company in Canada, is carrying out a study as well, looking at safety and effectiveness as well as cognitive performance with 3 different Kratom products. They have over 250 humans enrolled in those studies. And so those studies will be coming out later on this year as well. So just to say, again, long safe history use in Southeast Asia, lots of adversity in the Western world, but I really want to throw this disruptive pharmacology term out there and say that we've got something really important here. We just don't want to throw it away and ignore what the plant's trying to teach us. And I will stop there and thank you for your time and tons of people to acknowledge. And then the goose egg.
So we have, because I wanted to allow some time for some questions. We have 12 minutes for questions. I think we're going to start with Wade or that.
Yeah, hi Chris, thanks very much. You mentioned a couple of test subjects vomiting, and that's been my subjective effect. In fact, I once drove from San Rafael all the way to Palo Alto with a wonderful woman puking out the side of her car the entire way through rush hour. So that it has that effect. I've seen many people vomit, and from sources of the plant that are pretty reputable and I think pure. And it may be excessive dosage, but that seems to be a real problem.
Yeah. So this is a problem, and we spoke to a lot of the sort of normal users in Malaysia. I would say regular users. And they say that they titrate their doses almost to the point, if they really need extra boost, they'll titrate it up to the point where they start to feel nauseous. But they say that if you push the dose too high for anybody, it's going to cause vomiting. And so the risk of getting to toxicity is pretty low, because you should empty your stomach contents before you get there. However, you've seen there's a couple of examples where individuals that are experienced with opioids or experienced with other substances, they generally have to have they have a higher threshold for that nausea and vomiting effect. At least anecdotally, we haven't done any human trials to say that, but yeah, I mean, there's a lot of belief that this plant has its own sort of safety valve built in, that if you ingest too much, you're just gonna eliminate it. Interesting. Yes.
Yeah. Have you looked at the molecule with the
We
antifungal
have a,
molecule?
we have a mic right
Oh.
here. We wanna-
Yeah, I just wondered if you've looked at the molecule with the antifungal moiety cleaved off it and what activity it retains.
Yeah, so it's an excellent question, and in a paper by Dalbor Sems and Andrew Krugel, they have reported where they've cleaved that off, and it's interesting. If you do anything to disrupt that beta methoxyacrylate, that antifungal piece, you completely lose opioid activity. Anything you do to that moiety. So it has sort of a pseudo-aromaticity to it, and it seems to be the piece of the molecule that's actually in the deep lipophilic binding pocket of the opioid receptors. And so if you disrupt that, if you reduce the double bond that's in there, if you cleave the ester to the carboxylic acid, or if you even cleave off that whole vinyl ether moiety, you completely lose opioid activity.
Well, just one follow-up. Has anybody looked at training animals on kratom in a drug discrimination paradigm?
Mm-hmm. Yeah. In fact, we've published on that as well. But that's been my main pharmacology collaborator, Lance McMahon. He just left the University of Florida to become vice president of research at Texas Tech. But he is an expert in drug discrimination. That's what we've been focusing a lot on in that area. So yes, we've done it. The animals that are trained in that to become sort of connoisseurs, they'll partially recognize morphine or other opiates, but they don't fully substitute.
Yeah, thank you. That's a very impressive amount of work you've been doing over the years. I mean, I guess the fact that it doesn't precipitate opiate withdrawal kind of tells you in humans it isn't functioning as an opiate partial agonist, because buprenorphine clearly does. So we can be reassured in the human. I mean, presumably it doesn't precipitate withdrawal, otherwise people wouldn't use it.
No,
Yeah. Okay. And in your precipitated withdrawal study, which it reversed the popcorn bouncing, is that effect blocked by your himbine or? We were paying attention.
I hear you. So this is I think one of the probably most important things that we found, and I didn't talk about it because we haven't published it yet. But I will tell you, the manuscript is finalized and it's about ready to be submitted. Yes. So one of the most interesting things that we found is, as we were doing drug discrimination studies, we were pushing doses as high as we could to figure out what our training dose had to be, particularly with Mitragyna and purified Mitragyna. When we would push doses high enough with Mitragyna, we would see animals go into convulsions, which is consistent with what poison control centers are reporting as overdoses. Intuitively, we grabbed naloxone, couldn't save any of those animals. So I said to the guys, just throw some yohimbine in next time and see what happens. Totally resuscitated the animal. So we believe that the alpha adrenergic component is the key component of toxicity. And once we get this paper out, we actually show lofexidine and clonidine fully substituting for kratom. And so it's much more alpha adrenergic activity than what is reported in receptor binding profiles and whatnot. We don't know if that's due to metabolisms, due to I mean, we're starting to scratch the surface of this iceberg, and again, we're focused on alkaloids. There's a lot of other things in there. So, you know, I think it's going to be fascinating. And so that's one of the key pieces of information that emergency room physicians have asked us is what should we be treating people that are coming in and saying they're on Kratom. And we also have about ready to come out with a paper in pregnancy. So we've been looking, there's been a lot of reports in the literature on neonatal abstinence syndrome. After mothers that have been ingesting Kratom, they're having babies with issues. And we've been working on that question a lot with obstetricians and pediatricians and trying to figure out what's the right treatment paradigm for those babies. Do you want to put them on opioids and then all of a sudden you have them, you know, first at live, maybe they didn't have opioid problem and now they do. So really trying to figure out that piece of it. And when you're birthing pups that have been exposed to Kratom, they do come out with something that looks like withdrawal or abstinence compared to morphine. But that also looks like stimulant withdrawal. And so are we seeing opiate withdrawal and are we seeing stimulant withdrawal and mislabeling it opiate withdrawal and then putting the wrong treatment paradigms into place for those babies and giving them a bad start from the start? And so the real questions of what do we do? I would say at this point, what we've learned is that Kratom should not be used in pregnancy.
One more question?
Looks like you might be a free man. One more.
One more.
There's some water, the water.
So there's a lot of anecdotal usage of kratom and cannabis together. So curious if you could share with us what you think is the pharmacology that makes that such an attractive cocktail.
Yeah, so, all right, maybe in the next time in 5 years. I think Dennis, this needs to be an annual event, by the way. It's just too much to catch up with. We've started doing a lot of studies with cannabis and kratom together because it's hugely talked about on the internet. We started with the low legal hanging fruit, and that's CBD. And what we've seen is CBD increases the exposure of kratom alkaloids 3 times. And so there's a huge pharmacokinetic resulting in a huge pharmacodynamic effect. The other thing is we're seeing a cycling. And so plasma levels will actually increase like you normally think when you first ingest it. And then there's a second spike. And then that goes down, and then hours later, there's another spike after a single dose. So the only thing that we can think of right now, and again, it's something we're still working on, is that CBD is somehow facilitating transport of the alkaloids into the lymphatic system. And then as the lymphatic timing, the timing coincides with the spikes as to when the lymphatic circulation redumps into the plasma, or the blood supply, I guess. And so what we're seeing is those spikes, and that's what we think is happening. And we've started looking at removal of lymph nodes and trying to, look at concentration in the lymphatic system. But it's quite fascinating. So the anecdotal reports that people are putting out there, there's some science now that we can put behind it as to what's really going on. But yeah, fascinating stuff.
Thank you so much.
Thank you.
Thank you, Doctor. That was excellent. I only grasped part of it, but so many questions.
10-minute tea break, 1 minute before we have to be coming back into the space.
Lovely work. Thank you so much.
We'll be ringing a bell. So it's a 10-minute tea break. There's beautiful truffles outside. And I just want to reiterate that where Chris is the exit and the entrance. Our tech team is having a bit of a difficult time with a lot of traffic in the back. Thank you very much. See you in 10 minutes.